Hi, I'm Ann Sarah Padanga, and I'm the mother of two daughters. My younger daughter had a combined kidney and liver transplant about 15 years ago, and she's now 16 years old. I've been her primary medical caregiver her whole life. And honestly, my biggest fear is that she won't take good care of her kidney and her liver when she's an adult. So we've been talking about this next topic for many years. We're really excited to have you here today for this session entitled How to Effectively Transition from Pediatric to Adult Care, a Nephrology Example. I'm so delighted to introduce you to three people who will explain the components that are needed to successfully transition a transplant kid into a transplanted adult. Dr. Brad Warady is a professor of pediatrics at the University of Missouri Kansas City School of Medicine. He is the director of the Division of Nephrology and Dialysis and Transplantation at Children's Mercy Kansas City. He's also internationally recognized as a writer and researcher in the field of pediatric nephrology. He is the principal investigator of the NIH-funded Chronic Kidney Disease in Children study. Dr. Warady is also on the National Kidney Foundation board, and he is tirelessly advocating for children affected by kidney disease. We're also grateful to have Dr. Nicolas Herrera with us today. Dr. Herrera is assistant professor in the Division of Transplant Nephrology at the University of Kansas Health System and the Division of Pediatric Nephrology at Children's Mercy Hospital. And finally, we will hear from transplant recipient Jacob Carter. Jacob was born in 1998 with prune belly syndrome, a rare condition which included polycystic kidney disease. He received a living donor kidney transplant at Oklahoma Children's Hospital when he was only 18 months old. In 2006, he received his second living donor transplant at Children's Mercy in Kansas City and then transitioned to adult care in 2021. Jacob now works and attends college and enjoys sports and outdoor activities. And without further ado, I will turn it over to Dr. Warady.
Thank you, Ann Sarah. Well, it's a real pleasure to be here at the conference to speak with all of you. I'm honored to be amongst a list of some great speakers that you've already heard from over the last couple of days, and it's really a pleasure to talk to you about a topic that I really love to talk about. So, if I can have my first slide, Ann Sarah, there it is. Okay. So we're going to talk about transition today, and I'm really, again, pleased to have Nick Herrera and Jacob Carter alongside me, because I think that'll give us an opportunity to really talk about the whole spectrum of transition. Now, as we start, again, I want to wish everybody a happy National Donate Life Month, which is obviously extraordinarily important to all of you and to all of us in the healthcare field. And Sarah has talked to you a lot about my credibility as a speaker. But this is really what she didn't mention in terms of credibility. This is me and her daughter, Lauren, who is that transplant recipient. And I've had the opportunity to help the Padanga family care for Lauren over her 16 years of life. I think I've taught them something about transplant, and they've certainly taught me a lot about transplant as well. And one of the topics, as Ann Sarah mentioned, that we've been talking about, especially more recently, is that of transition. So transition has been something that's, again, been important to me for a number of years. This is from an article that I published back in 2011, some 11 years ago, with a friend of mine, Alan Watson. And Alan was one of the real leaders in the transition education from Nottingham, England. And in that article, we used this definition for healthcare transition: the purposeful planned process that addresses the medical, psychosocial, and educational needs of adolescents with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare systems. And then you'll see, again, a lot of different definitions of transition, but they're all on the same theme as what is noted here. Now, this is a really important slide because it nicely gives you a visualization of what that transition process is in a very simplistic manner. The transfer of care is the movement from the pediatric care center to the adult care center. But the transition process, which is really the education process, begins in pediatrics and generally continues through pediatrics and even into adult care. Because many of the adolescents and young adults do not have the skills for independent self-management by the time they transfer care, and thus we depend upon our adult providers to continue that transition education after the transfer has occurred. So this is the first slide that you're going to see that I'm emphasizing the collaboration between the pediatric care providers and the adult care providers that is so important if one is to have an optimal transition and transfer process. Now, what can happen when the process doesn't work well? This is again from Dr. Watkins' experience back in Nottingham, England. This is published in 2000. And in this situation, the adolescents, young adults were basically given a letter, a summary letter, and then were sent off to the adult care providers without any real preparation over time. And what we're looking at here are the serum creatinine levels of the patients. I don't have a pointer that works here, but on the left side of the slide, you see the creatinine. And as the numbers go higher, that means that the kidney function is poor. And these are all transplant patients. On the bottom of the slide there, you see T represents when they were transferred from pediatric to adult care. The negative numbers represent prior to transfer, and the positive numbers represent the months after transfer. And what you can see by all of the lines that are going up, those are individuals whose creatinine levels worsened. And in fact, out of the 20 individuals who are characterized here, 8 of them lost their kidney transplants within a period of 36 months after transfer. So this is what can happen in a worst case scenario in association with transfer. Now, this is more recent data from the United States Renal Data System. And this is a mandatory registry here in the US of all transplant recipients. And here, this is kidney transplant recipients. But what I'm telling you today really applies not only to kidney transplants, but to heart transplants and to liver transplants as well. But so here what we're looking at is graft failure rates. And the bottom there is the age of the individuals. And you can see by that curve, the graft failure rates or the loss of the transplants are most common between about 18 years of age and 25 years of age. And this is the period of time when the majority of these adolescents and young adults are being transferred from pediatric to adult care. So it's a very high risk period of time. And we believe that this high rate of graft loss is oftentimes due to non-adherence with the medical therapy. Now, when we see this, the question we asked was, well, why do they do that? And this is a cartoon that sort of tongue-in-cheek emphasizes some of the factors that may be contributing to the non-adherence we may see in the adolescent patient. So you can see in this brain, the biggest part of the brain is addressing the birds and the bees, or the memory for music, or the rebellion center, or all the answers. And in the front there of the brain, and the lower portion of the brain, you see the very, very small judgment gland. And that's sort of what we're dealing with in many of these individuals. Now, from a more physiologic standpoint, this is a brain again, and the limbic region is that region of the brain that addresses reward, immediate reward. And this is fully developed in the adolescent individual. And so that's why some adolescents will do things that we say aren't very smart, but they're looking for the individual reward, and they're not thinking about the consequences of their actions. In contrast, what's most important for an individual who is transferring care is to have a fully developed prefrontal cortex. Now, I say that's important because in that prefrontal cortex of the brain, you have developed the executive functions. And executive functions address the control of impulsive behavior, emotional regulation, reasoning, learning from experience, and planning. All characteristics that are critically important if one's going to independently self-manage their health care and if one is to have a successful transition and transfer of care. The problem here is that the prefrontal cortex is not fully developed, is not fully mature until the mid-20s. So we're taking individuals, we're moving them from pediatric to adult care, but in many situations, they don't have the, again, executive functions that really lends themselves to a successful experience. Now, the other thing I think we have to keep in mind as we're designing the successful transition and transplant program, or excuse me, transition and transfer program, is that doctor-patient family relationship. I think that this is so important that we really get into what are the strengths and the weaknesses of the individual who's transferring, of the family, so that we can build on those and try to optimize that transition and transfer process. One size doesn't fit all. We need to individualize the program that meets the needs of that adolescent and young adult and that family. And in my experience, we have to start with the quality of life. The quality of life is so important to these young individuals that anything that compromises the quality of life is not likely to be as successful as we hope. And if we look at children with advanced chronic kidney disease, this is what they tell us is their feelings in terms of themselves. So you can see on this slide, some of them feel inferior. They have an impaired body image. They're failing the expectations of themselves and others, and they have a sick identity. Others feel insecure, that there's uncertainty in their life. They feel vulnerable. And again, they have a doubtful future in their own minds. And then others feel that there's been an injustice. They're deprived of freedom because of their medical complications. They feel victims and they think they have lost opportunities that they might otherwise have if they were healthy. Now, some of them certainly have resilience and maturity associated with their chronic disease management, but I find that that is really the minority of the patients overall. And I think what we know oftentimes about our patients is really the tip of the iceberg. And there's much below the surface that we really need to try to get to so that we best understand our patients before they transfer to adult care. As one of my patients told me in the past, you don't really understand what we go through because you've never had to go through it. And they are actually absolutely correctly. And so we need to try to overcome that obstacle or that challenge and get to know our patients in the best way possible so that we can optimize the process for them. To that note, regular communication between the patient, the family, and the healthcare providers is an essential component of the transition and transfer process. And this is, I have this as an individual slide because I want you to remember this, that this really has a significant impact on the success of the transfer process. Now, the individual on the right there is Stuart Cameron. Stuart Cameron was a nephrologist from the UK who was really one of the leaders early on in understanding the need for a process as we move our pediatric patients from pediatric to adult care. And he wrote about it back in 1985. You can see here in this article entitled "The Continued Care of Pediatric Patients with Renal Disease into Adult Life." Then he wrote on this same subject in 2001, and he said the following: "However, it is disappointing to find that many of the points made about this process within nephrology when I first wrote about the topic 15 years ago remain opposite today." In other words, over a period of 15 years, there had been very little, if any, progress in terms of optimizing the transition and transfer process for our young individuals. Again, this is referring to kidney disease, but it holds true for liver and heart as well. So what I want to share now with you is what we've learned over the subsequent 21 years about this process. First of all, I think we better understand some of the barriers to effective transition care. This is, again, an article from 2014, and I've highlighted three very common barriers. Number one, on the top of the slide, the patient is emotionally attached to the nurturing pediatric unit. We know that this is almost always the case. We love our patients love us, thankfully, and we have a relationship that nobody wants to see go away. Equally important is that second point. The parent is emotionally attached to the pediatric unit. And then lastly, the third one that's highlighted there, difficulty getting parents to let go and allow the young person to self-care. And this is difficult, especially when you as parents really have nurtured the development of your child with a chronic illness over years. And now, again, we're asking you to let them be a bit more independent, recognizing they're going to fall down. Now, they're going to get up as well, but it's hard to see them fall down when you know that the way you would have managed it might be a bit different. So these are, again, major challenges for us that we can overcome, but we must overcome if we're going to have a successful transfer process. This is a slide from Japan that looked at services, again, transition services from pediatric to adult care in 100 different units in Japan. Now, interestingly, only 4% of the units, or 4 units, actually had a curriculum, a formal transition and transfer curriculum. And the reason that these services were not enacted in these sites, as you can see on the right part of the slide, is that in 42% of cases, there was a refusal of the patients or the families to even want to transfer. Again, the reasons I just talked to you about. They're, again, hooked into their nurturing pediatric unit. And then in a third of the situations, there was actually a complete lack of concern about the transition or an inability to decide about transfer. So this is what we don't want to see. This is what, again, has happened in the past, as Dr. Cameron mentioned, and we need to move forward. And so to move forward, there was this publication in 2011. This was from the American Academy of Pediatrics, and you can see it was a clinical report on supporting the healthcare transition from adolescence to adulthood in the medical home. And in that publication, it stated the following: the goal of a planned healthcare transition is to maximize lifelong functioning and well-being for all youth, including those who have special healthcare needs and those who do not. This process includes ensuring that high-quality, developmentally appropriate healthcare services are available in an uninterrupted manner as the person moves from adolescence to adulthood. Again, emphasizing that collaboration from pediatrics to adult care. Now, they put together this algorithm in this publication, and you can see there's sort of 4 different components to it. On the left part of the slide, you can see that it starts at 12 to 13 years of age, where the providers should begin to have a discussion about transition policies with the youth and their parents. At 14 to 15 years of age, they make sure step 1 is complete, and then institute that joint transition plan with the youth and the parents. At 16 to 17 years of age, again, make sure that step 1 and step 2 have been addressed, review and update the plan, prepare for moving to adult care, and maybe here initiate a pre-transfer visit of that adolescent and young adult to the adult medical home so they can become familiar with those individuals who they will ultimately be cared for by. And then finally, at more than 18 years of age, review all the prior steps and then move on to the adult care model. So this is the algorithm that should be used not as a mandate, but as a guideline for individuals that are moving from pediatric to adult care. Now, this is a more recent algorithm, and I really like this algorithm a lot. It was just published this last year. And again, I don't have a pointer, so I'm going to take you through it slowly. On the top, you can see the arrow addresses on the left side of the slide, pediatric-focused transplant care. In the middle, it's the transition process, and then there's the transfer of care, and then adult-focused transplant care. Then if we go to the circles, you can see, if you focus on the parent manager, on the left part of the slide, starting at 10 to 12 years of age, there's the parent manager and the adolescent young adult participant. And then it moves to the parent supervisor and the AYA manager in training. At more than 16 years of age, late transition, the parent becomes the consultant and the adolescent young adult is the manager of their healthcare tasks. And then post-transfer, after they've moved from pediatric to adult care, the parent remains a consultant and the adolescent and young adult is the CEO of their care. And I think this really nicely delineates in a cartoon, if you will, at how the changes should occur in terms of self-management over time. On the bottom, you can see that the sort of management skills that should be developed at these different components of the transition process. And in terms of outcomes, we hope for a successful outcomes in terms of a number of them: physical functioning, health-related quality of life, adherence with their therapy, healthcare utilization, and allograft function. Now, in 2011, there was also publications from the International Society of Nephrology and the International Pediatric Nephrology Association, again, giving recommendations about transition and transfer. And I want to emphasize again, what they recommend here is applicable to all transplant recipients, irrespective of which organ is being transplanted. And they stated that transfer should be individualized for each patient after he or she has completed a transition plan. There needs to be a plan that begins in the pediatric unit. Transfer should be agreed upon jointly by the patient and his or her family in conjunction with the pediatric and adult care teams, that collaboration. Young people should be introduced to the concept of transition in early adolescence. And very importantly, transition should be directed by lead clinicians or transition champions in pediatric and adult units to coordinate and educate on transition issues. It's easy to have a pediatric champion. It's more challenging to have an adult champion, and Dr. Herrera we'll certainly talk about that very soon. Now, also in the consensus statement, the transition plan should include parents and other family members and even boyfriends and girlfriends. Young people should be offered the opportunity of an informal visit or visits to the nominated adult service before the transfer occurs. Just like the AAP said, again, make people more familiar with the adult care providers. And then a transition or transfer clinic in either the adult or pediatric unit with both adult and pediatric healthcare teams in attendance is the optimum minimal standard. So again, collaboration between the pediatric and adult providers. Now, the OPTN in 2018 suggests that these are some critical milestones that the adolescent and young adults should achieve as they move to adult care. They should be able to describe their original cause of their organ failure and the need for transplant. They should be able to characterize and describe the long and short-term implications of transplant on their overall health, taking into consideration things such as infection risk, cancer surveillance, and vocational aspirations. They should know the effect of the illness on their sexuality and reproductive health. They should have the capacity to provide most self-care independently. Not necessarily all, but most self-care independently. In turn, they should have a sense of responsibility for their own health care. They should express a readiness to move into adulthood. They shouldn't be pushed out the door, but have a readiness to move. And then they should own medical information in a portable summary themselves. Now, we can't expect these adolescents, young adults to just become knowledgeable just out of thin air. You have to define, you have to generate a curriculum to educate them over time. This is our curriculum at Children's Mercy Kansas City. It's called the KEYS program, and we've had this for a number of years, but we've continued to enhance it over the years. And KEYS stands for Kidney Education for Your Success. And we cover the gamut of information that these individuals need to know so that they can independently self-manage themselves in terms of their health care when they transfer from pediatric to adult care. I think one of the other components of this whole process that's critically important is a readiness tool. Having a readiness tool that you repeatedly review with the adolescent and young adult to make sure that they are educated on a number of different topics that you believe are important for them to be educated about as they move from pediatric to adult care. So our readiness tool, as you can see here, addresses chronic kidney disease, but addresses medications, it addresses lab information, it addresses overall health, as well as self-management skills, insurance, and ongoing support. And one of the things I want to emphasize about this tool, which I should say we give it to these kids pretty much on a yearly basis up until they're about 19 years of age, and then we do it twice a year. We don't just ask questions where there are yes or no answers. We ask questions oftentimes where it requires an explanation, so we know that they really understand it and can't just sort of say, yes, I know that. They have to explain it to us. And so I think that this is a key aspect of the transition education. And I should also add that if we get to a point where we have a young adult who is ready to move to adult care, but is not fully educated on certain topics, this readiness tool goes with them to their adult providers so that the adult providers understand what education still has to occur after they've transferred from pediatric to adult care. Now, one of the questions that often gets asked is, well, what's the best age when these individuals should transfer care? And there's not a lot of information. And this is a busy slide, but this was a slide done by Beth Foster, who's a pediatric nephrologist in Canada, where she looked at data on over 400 children, transplant recipients, as they moved from pediatric to adult care. And as you can see on the right part of the slide, some of them were transferred early, and early means they were transferred before 21 years of age, and others were transferred late on the upper part of the slide at more than 21 years of age. And then they looked at how many of them had lost their kidney transplants between 21 and 30 years of age. And as you can see on the bottom right, the failure rate of those who were transferred early, meaning before 21 years of age, their failure rate was 12.9 per 100 patient years. If we look at the top, those who were transferred after 21 years of age, their failure rate was 8.7 per 100 person years. So this data, of which there is limited such data, suggests that maybe at more than 21 years of age, maybe when that prefrontal cortex is more mature, might be a better time to transfer these individuals prior to an earlier age. Okay, very importantly, what are the perspectives of the emerging adults? This slide is what one individual saw when he first went to the adult kidney transplant clinic. My fears were confirmed. The environment was alien and much less comforting. Most of the other patients looked older than 60 years of age, and there were new ways of checking in and taking blood. Posters of cartoon characters had been replaced by skin cancer alerts. We have to recognize those concerns and address them. And Alison Tong, a researcher, generated these major themes after talking to many adolescents and young adults who were transplant recipients who had transferred. And this is what they told her. Number one, in terms of timing of transfer, it should not be determined solely by age. It should be considered within the context of life events. In terms of being sterile and unwelcome, they did say that the clinic appointments in adult care were short, impersonal, and cold. They felt displaced, isolated, and lonely in the waiting room, surrounded by a large number of older patients. And it'll be, again, very interesting to hear what Dr. Herrera has to say about that. They felt from an independent standpoint that transition and transfer did facilitate an increased sense of maturity. In terms of access to providers, they thought that it was very important to have the opportunity to establish positive relationships with adult healthcare providers prior to formal transfer. Patients need to be comfortable with the adult provider and to have ongoing access to their pediatric provider. Again, that collaboration. And then finally, active involvement of parents facilitated preparedness for transition and transfer. And indeed, throughout the literature, we'll see involvement of a supportive parent may be the most important factor in successful transition. And at Children's Mercy, prior to COVID, we regularly worked with our adult providers in our community at two of our major centers who received many of our individuals who were moving from pediatric to adult care. We worked together, we learned from each other. And again, we sat at the table and said, how can we improve on what we're doing? Let's talk about our successes, let's talk about our failures, and enhance the transition program together. This is just a slide that talks about what sometimes is not being able to be provided in adult units. And I know Nick's going to be talking about that. But again, what I want to emphasize is, although adult medical providers have the role of assuming the care and management of these youth, they should not be expected to do so without supports that are more readily available to pediatric providers. And in turn, adult providers should not expect a handoff from pediatric practices, but rather a handshake. Again, the collaboration is exceedingly important. So the task for the adult team, they need to learn about the developmental stages of adolescence and about, again, chronic disease and the pediatric population. They need to designate a transition coordinator to help facilitate the transfer process. They need to develop a mechanism to facilitate not only pre-transfer dialogue, but post-transfer dialogue to continue to improve the transition process. And then pediatrics and adults need to work together to develop these transition clinics. The challenges of transition clinics, number one, defining transition champions in pediatrics and more so in adult units. These individuals are a small percentage of the patients that are seen in adult programs, so this is a significant challenge. Another challenge is facilitating these face-to-face visits between the patient, the parents, and the adult care providers, especially when it's a freestanding children's hospital and there is no adult hospital just across the road. Developing transition plans jointly with adult providers, that's key. And then finally, institution of that pediatric transplant program and celebrating the transfer when they move from pediatric to adult care. Recently, actually right before the COVID, we had a workshop for the National Kidney Foundation where we invited, as you can see here, a lot of people, including healthcare providers, nephrologists, nurses, psychologists, cardiologists, as well as patients and parents to say, how can we better care for these adolescents, these young adults with chronic disease? And as it related to the transition process, these are the priorities. A transition champion or leader at the pediatric and adult nephrology office was imperative. A portion of each patient visit should be conducted without the parent or caregiver starting at age 12. I didn't speak to that previously, but this is an important part of that independence that we're trying to generate. Progress with transition education should be monitored with a transition readiness tool. The parents told us this themselves. There should be a transfer letter put together with a succinct summary that is shared with the adult provider, but also shared with the emerging adult patient. Importantly, patient and provider expectations should be discussed at the initial visit between the emerging adult patient and the adult nephrology provider. They have to each know what each is expected to do. They have to be on the same page. And then finally, parental guidance and support during the child's transition and transfer to adult care is essential. So in closing, we in pediatrics love to take care of our young kids, especially those kids who have complex disorders. And again, ideally, they all grow, they all develop, and again, they move on to adult care. And we should be celebrating when they move to adult care and not being too over anxious about it. Because while it is the end of their pediatric experience, it's just the beginning for these young emerging adults. So thank you very much for your attention. And Sarah, I'll hand it back to you.
Great. Thank you so much. That was really great, Dr. Warady. We appreciate that. We will have a chance for questions at the end of these presentations, so please enter them into the chat. Now I'd like to introduce Dr. Herrera for his presentation.
Hello, thank you. Let me share my screen and share. How's that? Oh, perfect. All right, so thank you, Dr. Warady, for your presentation on the considerable process of transition from the pediatric world to the adult world. Thank you all for coming today. I am Nick Herrera. I am an adult and pediatric nephrologist. I have my foot in both worlds. It is my dream job and my passion, just like Dr. Warady's, to help manage these very difficult patients with very complex and chronic illnesses move from the pediatric world to the adult world successfully for their best outcomes. And so I'm sure by listening to Dr. Warady talk about the complexities and the time frame involved of the overall process of transition from pediatrics, I'm sure you can appreciate the process is a very difficult one and a very complex one. But that complexity doesn't end in pediatrics. There it goes. The hurdles exist in the adult world as well. This meme aside, as an internist myself, I understand that many other internists tend to feel very comfortable with many diseases as we are trained throughout our residency programs. And despite that being an overall mantra in internal medicine, the truth of the matter is that many internists feel the need for improved training for complex pediatric diseases. You can find studies that go back well into the early 90s that describe um, uh, internist comfort with complex pediatric diseases. But in more recent time, you know, when you talk, these most recent studies here published in 2010, 2013, were surveys sent out to internal medicine residents, so trainees, before they graduate to become full-fledged attendings, many of whom in these surveys have reported that their overall training in complex pediatric derived diseases and illnesses, that their training is not adequate to manage these patients long term. And I point out the second survey here in 2013, survey of more residents, a combination of internal medicine, so basically those physicians that just manage adult patients, and then also with med peds or MP, internal medicine and pediatric physicians like myself. The difference between the two groups, that med peds tend to have more comfort with these complex diseases because we see them in the pediatric world. And after residency, as these young physicians move over into the adult primary care world, that impact of their training and what they're comfortable with also impacts their overall patient diversity and patient background that they manage going forward. This is another paper published in Pediatrics in 2010 that looks at the overall likelihood that an internist here in dark gray here are likely to manage these complex pediatric illnesses in their primary care clinic. The ones bolded here in red or boxed in red are very significant in terms of their overall comparedness to the pediatrician. So autism, cerebral palsy, behavioral developmental, Down syndrome, cystic fibrosis, many complex diseases which are now, with modern advances in medicine, many of these patients are moving into the adult world, necessitating a transition process or transfer process like Dr. Warady and myself are attempting to do in transplant. Even amongst nephrologists, the comfort level, as pointed out by this survey published in Chronic Kidney Disease in 2005, showcases the overall adult nephrologist comfort in managing pediatric diseases and chronic pediatric illnesses. The majority of nephrologists are not comfortable, either somewhat comfortable, depending on which disease process we're talking about, to not comfortable at all. And almost as many adult nephrologists, are not comfortable managing these more complex patients. And this is another slide. To be quite fair, if you're going to steal from the best. I took this directly from Dr. Warady. But I didn't actually know this data existed until we were kind of reviewing for this talk. And this is an excellent point that Dr. Warady has brought up in lectures in the past. But adult dialysis units support staff for patients with special needs. If you look here, all centers, United States of America, USA here, centers with transition programs and centers without transmission programs in the USA, you can see that the total number of 12, total number of 26, but virtually none really have the necessary support staff or the support measures to address these issues with these complex needs like developmental delay or adherence issues. And that really is a shame. It really does kind of support the need for additional resources in this field. And so, beyond the need for specialized adult provider experience and support for successful transfer from pediatrics to adult care, as Dr. Warady has pointed out in his talk, many young adult patients who transfer feel very apprehensive about that transfer process, very anxious. And so this is where I work here at Kansas University Medical Center here, KU. And even though it's a very pretty institution, very nice and friendly looking, I'm sure many of the young adult patients who transfer see my institution something more similar to this, which is a little more ominous and a little bit more intimidating, to say the least. But the reality of what we're trying to do, both Dr. Warady and myself, throughout this whole process of transfer and transition, our major goal is to essentially relieve the stress and anxiety to that experience. And most of that process occurs well before transfer, well before the patient ever comes to me or meets me or introduces them to me. As Dr. Warady points out, a lot of this transition process occurs years before they actually get to the point where they may begin the transition, the transfer process. And so, even my part, accepting the patient on the adult side, begins before you may think. Before we actually have them in the adult center, I actually meet with the Children's Mercy team, the patient and their support team, their support person. I introduce myself. I tell the patient and their support person what to expect coming to my visit, who they're expected to meet, what kind of process that's going to be. I answer any questions or hesitations they may have, and really just kind of introducing myself as someone that's going to be managing them going forward. And so at KU, I accept all transplanted patients transitioning from Children's Mercy. The first clinic, which is the first clinic after I see them as part of the Children's Mercy team, is multidisciplinary. It has myself, a post transplant nurse coordinator, social work, pharmacy, and a nutrition. Um, Support people are welcomed. The first visit is really meant to be introductory. This is where you get your labs. This is what the office looks like, where the building looks like, where you park, all those kinds of things. But also importantly, where I describe the goals and expectations that I have as their up and coming physician that's managing them going forward. But not only my expectations, but also their expectations coming from children's, what they want to see, what they would like to do, and what they would like to get out of this process. But very early on, just like Dr. Warady said in his talk, that this is the time frame where I really sit back and I kind of push the patient a little bit further in self-management, self-care, and more responsibility. That plus the rest of the atmosphere of being over in the adult hospital really begins to kickstart that process, in my opinion, even further than already done in the pediatric world. So after they see me, they return back to Children's Mercy, CMH, to see the pediatric team once more before their final goodbyes, their final visit, before they come back to see me within about 3 months so that I can assume care. And so all that process occurs no more than 6 months from when I see them in my clinic to when I see them again to assume care. Really, just to make sure that no balls are dropped and that everything moves smoothly and consistently. So this clinic is quarterly in nature, every 3 months. It's scheduled on Thursday mornings. It's very consistent, and it's meant to be that way. So it kind of relieves that pressure of what days do I need to be here? What days does Dr. Herrera have open? No, if I am available, if doesn't matter what else is going on, if it's the 3 month time period, that's when I'm there to see these patients. These clinics are staffed with consistent providers, myself, the support staff I mentioned earlier. Um, these patients remain in this clinic for a minimum of 1 year. So that's 4 visits after transfer. And it's done that way specifically because I felt the need that consistency is key with a lot of these patients and routine. And so once they get to a point after a year that they feel more comfortable in the adult world, what to expect, what their labs look like, how their insurance is going to change, the people that they're dealing with, then I may allow them to move to a general adult transplant clinic. These appointments are 40 minutes long, and no less, regardless if you're a new patient or a follow up. There is no overbooking allowed. And I specifically keep this open space on this particular day because there are less uh, other clinics open at that time frame. So that burden in the waiting room of significant patient um, um, amounts that are waiting for new visits are lower. And so, if you know anything about the adult world, sometimes our clinic visits are very, very short. And that's not conducive, in my opinion, to this type of patient population and relationship that I'm trying to establish. In these appointments, I spend about 1/3 of my time just addressing things that are not medical related. So, how are you? How are things? How's school going? How's work? How's your boyfriend or your girlfriend? And really trying to get a sense for how they're doing mentally, emotionally, spiritually, not just medically. And if there's any concerns whatsoever from any of those aspects, I get them to the right resources, the right support, whether it's social work, pharmacy, depression, anxiety. I either treat myself or get them to the right people. And a shout out to Dr. Carrie Strumpf, who is a psychologist, PhD. I send many of my patients to as a specialist in pediatric chronic illnesses. She's been tremendous help. And this is my team. It's a very consistent team. You're going to be seeing one of these, well, all of these individuals in your transfer process. Terry Bloomer has been doing transplant for over 30 years in the adult world, obviously, but she is a mother hen, and I couldn't do this without her. She sees all of my adult patients and my transfer patients as well. So it's very consistent, me and her. Our social worker, Elizabeth Kelsey, Dr. Strumpf, our dietitian, Angela, and our pharmacist. Fantastic group, great people, very warm and affectionate. If I didn't know any better, I would say they're coming straight from pediatrics. They fit this mentality and energy as any pediatric individual would. And so this clinic is still in development. You know, this is a kind of a new process as a whole, developing an adult receptive clinic. On a national level, it's just one of these things that you need to have the right, as Dr. Warady said, champion on the adult side to kind of further these kinds of endeavors. And so this is still a motion that needs development and needs to be flushed out further and further. And so surveys are constantly being utilized, or we're working on a survey right now to try and improve that process of transfer for both patients and providers and everyone involved. And the goal for a lot of this, like I said, is consistency and familiarity for our patients. And if you were to ask me what my personal goal is, like Dr. Warady said, you know, when these patients come from peds to adult, it's a different environment, an alien environment, as we say. If we could just pick a chunk out of the pediatric hospital, move it over and put it down in my adult hospital with turtle and teddy bear paintings on the wall, that's what I would do. But, you know, that's kind of the mentality that I want to bring here, but just a half step into the adult world. And that's really the key to this. But yeah, that's what I would like to see done. So that's the end of my talk. And with that, like I said, thank you for coming and thank you for listening.
Thank you so much, Dr. Herrera. That's really an incredible program to see the connection between Children's Mercy and KU Med. It's a wonderful example of how transition can happen effectively. And I think now it's time to hear from Jacob Carter. If we could add Jacob to, hi, Jacob.
Hello, how are
thank
you?
you so much thanks for being here with us today. It's wonderful to have you here. And
yeah, you
we want to talk to you a little bit about your experience, because you are an example of someone who's come from one program in pediatric and gone to an adult program. And so we just want to know a little bit more about your perspective. So I have a couple questions for you, and then we'll bring Dr. Herrera and Dr. Warady on for a couple questions. So mostly we're kind of wondering, you know, was it a scary thought when you were thinking about transitioning into adult care?
Well, so basically from like as far back as I can remember being there at Children's up until about 16 or 17, I was just learning the basics about my kidney disease and learning what to do and what not to do. And so I never really heard of like being transferred to adult care, maybe like once or twice, but then I got like probably around 16 or 17, I started assuming that I would be getting out of pediatric care and Dr. Warady's care at 18. And so I was very, very scared and unprepared, to say the least, about it all. And but then Dr. Warady and his team definitely came to my rescue and immediately said, it's 22 whenever you get out. So those 4 years of definitely extra knowledge and preparation set me on a course for success, I think.
That's great. That's really great. You had a couple more years to prepare yourself. But when we spoke before, you told me that there were some things you were doing ahead of time. What types of things were you doing before that to take care of yourself, to kind of get yourself ready for the transition process?
I had learned to definitely set an alarm whenever I needed to take any sort of medicine. I was taught at a very young age, and still kind of go by it by habit, is just bring a water bottle with you wherever you go. Don't rely on like a water fountain. Like three drinks of water gets you, I don't know how much, but just make sure you bring a water with you so that you can constantly fill it up and drink it. And it's actually a really good measuring tool as well.
That's great. So you're taking care of your kidney, doing a good job doing that.
Mm-hmm.
Jacob, what can you tell us? Could you give advice to any other kids who are going to transition into adult care? What types of things should they make sure that they're thinking about or planning for in the future?
Definitely be prepared to face many different aspects of life coming at you. Like, make sure that you can definitely balance it out. That's probably the main thing that you probably need to do. Like, between work or college or school, relationships with people, and then on the medical side of things, as water, taking your medicine right, ordering your medicine, and possibly insurance on top of that. And so just make sure that you're on the ball for every little thing, and don't let any slip ups happen health wise, because health wise any slip ups could be pretty bad.
Right. Yeah, those are all important things to do. And so what about for parents? What about caregivers? Did you have help in learning how to do all those things? And what advice do you have for other caregivers to help their families, their patients?
Yeah, so I definitely had a lot of help from my mom. She was definitely kind of like definitely a safety net, and but she was basically just kind of supporting me. She knew that I was learning it all along. As a parent to a caregiver, though, I would say that you should always kind of be like one level above in knowledge about your child's disease. And so so over time your kid will they're kind of going to be comfortable with like in-clinic questions. If the parent definitely wants to ask questions, and the kid's kind of going to subconsciously be there and already know the answer over time, and eventually your one level of knowledge, it's going to be kind of matched with your kid's knowledge, because your kid's going to learn a lot more that you ever thought that they would, because you're kind of just subconsciously asking questions and doing it for yourself, but then you don't realize that your kid is also definitely getting up to your level of knowledge.
Okay, that's so interesting. So you're saying that because your parents were on it, your mom was really learning about what needed to happen. You learned from that. You heard your mom in conversations so that you learned. That's a really important thing to relay to everybody. That's fantastic. Thank you, Jacob. And I think if we could, I know we're running short on time here, but we have a lot of questions here. If we could bring Dr. Warady back on and Dr. Herrera, please. Great. Hi there. Thank you so much for presenting.
I just want to say, Jake, I don't know about anybody else, but I feel so good after hearing what Jacob just said. And I wish I could take credit for it all, but I can't take credit. He's done a fantastic job. And next time I think you'll have an hour session. We'll listen to Jacob for 50 minutes, and then Dr. Herrera and I will come in at the end.
I agree.
Right. Yeah, no, I think that's great. I think he has a lot to tell us and to share with us. It's really wonderful. Okay, but I think I should ask a couple questions we had here that came in. Let's see, at what age do most hospitals no longer consider a transplant patient of pediatric age? Dr. Warady, do you know, or
yeah,
Dr.
it varies. You know, it's certainly, it can be 18 years in some centers. I know in Canada, it's often 18 years. In many other centers, it's 21. You know, we keep patients, as Jacob mentioned, up to their 22nd birthday. And, you know, we sort of looked at that data, like I shared, that maybe people are going to be more successful in that transition and transfer if they transfer after 21 years of age, when that prefrontal cortex is developed. So, but I think it varies between 18 and 21 years of age, 22, based upon the center.
Okay. And we've got one here a question, is it possible that the increased rates of rejection once transitioned to adult care is a reflection of the adult transplant management system? My biggest unease as a parent is that my son will fall through the medical cracks once he's in the adult system. Dr. Herrera, do you want to take that question?
I completely understand your point of view and your tribulations about that. To there's no difference. It's not like we use different medicines. We don't use a different formulation. We don't do medications on a different frequency, or we don't aim for different goals. There's nothing about the medicine portion of this that can incur a higher risk of rejection. A lot of this has to do with how well this transition process is managed, both on the pediatric and the adult side in particular. Slipping through the cracks, as you mentioned, is a very important fear that a lot of us adult nephrologists have when it comes to accepting and treating and managing these patients that come from the pediatric world. I would say that you know we think about it from the general internist or the adult nephrologist. That mentality of how they manage the adult patient has a lot more responsibility on the patient than the pediatric patients may be used to, and that may incur some element of this. But I think that the overall difference between the adult and the pediatric programs just comes down to how well we prepared the patient, and then how well we continue preparing the patient after they've come to the adult world.
Okay, thank you. Here's another question. Any tips for a transplant center looking to start a transition clinic? Any resources that were instrumental in getting started? Dr. Warady?
Well, I think the first thing you have to have is that transition transfer champion. You have to have somebody really on both sides of the road, right? Both in a pediatric and adult, who have a passion for transition and transfer. And that's the first step. Once you have that, they can sort of take the ball and hopefully run with it. And it's labor intensive. It's not simple. Designing a curriculum, having the support both on the pediatric and adult side from the psychologists and the nurses and the physicians. It's not easy, but you have to have that champion on both sides if it's ever going to be successful.
Okay.
Nick, would you agree with that?
Good point.
100% agree. Finding that one person, like you said, on the adult side that has that passion to run with it, like you said, is that's what makes this program possible. I agree.
Okay, great. Thank you. What about, at what point should providers start training caregivers to start letting go?
Well, I'll say a few words, then Nick can talk. As I suggested in one of my slides, the suggestion is that you should start having some time with that adolescent alone in the clinic without the parents in the room, 12, 13 years of age. And I think that's the beginning. And Jacob could speak to that as well. But I think that's how you begin to develop that independence, to begin to sort of stretch that umbilical cord a little bit. Jacob, what are your thoughts?
Yeah, definitely. I don't quite remember which clinic it was, but I do remember there was one clinic with you, Dr. Warady, that I know my mom came to every clinic, and she had to step out for one of them, and you guys were asking me questions that Dr. Herrera would ask me, and I couldn't tell you how I did, but I think I did pretty good.
You did.
Yes, you did.
I'm sure you did.
And if I could add in one more little thing about that is, even though that may be the case in preparing, caregivers to let go early, it's never going to be gone. I was talking earlier. I actually had a clinic the other day with one of my patients who was 50 years old after a kidney transplant, brought his mother to the clinic at 72. So
Right.
that kind of caregiver and compassion for your child and thing, that never goes away. So they're always good resources to have.
Right. And like the one slide I showed, the parent is always the consultant the young adult is now the CEO, but that consultant is always valuable.
That's very true. That's very true. Well, I am so sorry, but we are needing to wrap up now, and we have so many more things we could talk about, but I really cannot thank you enough for all three of you being here today and sharing this transition conversation with us. Thank you so much. We really appreciate it.
You're welcome. Thank you, everybody. Thanks.
My pleasure.
All right, bye. See you, Jacob.
Thank you.
Bye.
Bye.